cranial bone here, cranial base. And then we have a pterygoid process. This is a palatine bone behind the maxilla. We have a vertical plate, horizontal plate. Vertical plate of the palatine bone interlocks with the pterygoid process, forming the lateral walls of the nasal cavity in the posterior part of the nasal cavity. So again, this is also a posterior resistance. So 2 out of 3 posterior resistance. So all the circles here offer the resistance against expansion. This is a very important concept. Many people ignore this, but we must understand what we're up against. So let's consider our traditional expander. Probably one of the most popular one is the Hyrax, right? Or Haas. Hyrax probably more popular than Haas. So let's consider the resistance, all the red circles here. And the way the appliance is designed here, what will be the expansion force? Right there. Probably near the premolar. So the position of expansion force versus the resistance. Expansion force is more anterior relative to the main resistance. So naturally, result's gonna be that we get more anterior expansion than the posterior expansion. Makes sense, right? And you see these 2 different color arrows. Red, throughout my presentation, when you see red arrow, that means the skeletal changes. When you see black, that's dental changes, dental alveolar changes. So since this is a tooth bone device, we're trying to split the suture, but you're gonna move the teeth at the same time. So often we call this kind of expander the hybrid device, skeletal component and also dental alveolar component. So Dr. Nelson also did some study with Hyrax, and she said the pterygopalatine suture appears to be fused at a certain age. And with Hyrax, it's almost impossible to overcome the pterygopalatine suture. So she called this suture a hinge, like a door hinge. So you get predominantly anterior expansion, and very little posterior expansion. So in a nutshell, this is what you get with Hyrax. Predominantly anterior expansion, very little posterior expansion. If we evaluate what Hyrax does from the frontal view, it's like this as well. In children, suture is patent. So you get pretty significant skeletal changes. In adults, not so much, right? Suture is interlocked. So we get very little skeletal change. But the real problem comes with the appliance design. It's a tooth-bone device way down here. So you push from down here. So you get more inferior expansion, much less superior expansion. In adults, same thing, but more dental tipping. So the pattern of expansion is the same, but you get more tipping, dental tipping with adults, more skeletal component with children. So let me show you one other case. We used to do a lot of Hyrax expansion. So here's a young patient. We did the Hyrax expansion. We were able to get the laterals to come in. If you look at the palatal vault here, kind of sharp edge, became flat, right? What does that mean? We probably moved the jawbone, some skeletal movement. But you can see, but how much was the skeletal? Here's the basal bone width, intermolar width, before, after. So we compare. So there's some skeletal changes. But look at the magnitude of change here. It's greater than up here. Why? This change here has 3 components. Skeletal component, bone bending, dental tipping, right? On the bottom, 3 different components. Up top, only one, skeletal. So you can see, net result was more inferior expansion, less superior expansion. And whenever we have a skeletal changes, you can also expect nasal cavity width change. This is very consistent with every case. It doesn't matter what appliance you use. Whenever you have a skeletal widening, you can expect a nasal cavity widening as well. So let's look at another case. This guy was 14. Can you split the suture in 14-year-old? We should be able to, but how much skeletal expansion can we get? So here's the case. We did the expansion. You can see we expanded pretty good amount. Now, question is, how much of this was a skeletal in nature? Remember 3 components, right? How much of this was a skeletal? Let's evaluate. Okay, originally, you can see 6 sitting more palatally than 7, right? After the expansion, the opposite. Now 6 is sitting further out than the 7. Also, you can see this appliance did not reach all the way back to 7. 7 was independent. So whatever changes occurred from here to there, which is because of the skeletal changes, not from dental changes. So if we consider the difference between yellow and blue line, that's how much dental alveolar changes we got with Hyrax. A lot, right? And how much skeletal change did we get in 14-year-old? Some, you can see split here, right? So even at 14, we can split the suture with the Hyrax. But very small amount, very limited amount. On the other hand, if you consider the dental inclination was like this, became like that. What does that mean? Loss of dental flare. Okay? So some skeletal changes, but mostly dental alveolar changes. So let's look at the 3D images, 3D superimposition. Some skeletal change, but very little. Mostly dental alveolar here. So even at 14 is a pretty young patient. Even at 14, you don't get a whole lot of skeletal change with the Hyrax. Lots of dental alveolar flare. So this research back in 2008 was just showing 3 different components of maxillary expansion. They were dealing with the younger patient, not 14, 6, 7, 8-year-old kids. So when they looked at the skeletal component, you can see about 38%, less than 40% skeletal, even in young patients. And when we look at the bone bending, about 13%. But what's really shocking is this one, dental tipping, almost 50%. So whenever you use Hyrax, even in young patients like 6, maybe 5, you get a lot of dental tipping. Why? Because it's a tooth-borne device. You cannot avoid this. And dental tipping and bone bending will flare the molars like this, right? So what would that do? It's going to drop the lingual cusp. So a lot of these tipping can cause bite opening in high-angle cases. And since we have to decompensate, bring them home during the orthodontic treatment, you get a lot of relapse. That's why we were told to overexpand with the Hyrax, because you're gonna have to decompensate them. So many researchers showing this, what we call the V-shaped expansion. Very little superior expansion, much predominantly inferior expansion. So typically with the Hyrax, this is what you see. The V-shaped expansion from the occlusal view, V-shaped expansion from the frontal view. This is something we have to deal with. What about SARPI? you hear me? Can you hear me back there? Maybe a little further up. 1, 2, 3. Better? Okay. So what about SRP? Are we getting the same thing? Well, obviously SRP, we expect more skeletal changes, right? Because surgeon will reduce the level of resistance. So we can expect much higher, greater magnitude of skeletal changes. However, we're using the same appliance, this one device. So we loosen the bone here, but we're pushing apart from down here. So what would happen? Two have hemimaxilla will roll away from each other. They bend away like this, right? So you end up with result like this. Very little superior expansion, much more inferior expansion. And also, the fulcrum is at the osteotomy side. You see very little changes up above. Most of the expansion is below the cut, right? So very limited superior expansion with SRP. So here's a case. Did the surgical sutures? What does that mean? The surgery was done about a week ago, right? Huge change here. So you get lots of expansion very quickly. So a lot of skeletal changes. However, changes are not most ideal. Why? Let's look at this one. 18-year-old. Massive transverse problem. So we did the SRP. And again, huge space. Very quickly. But look at what happened to the bite. I opened up. So with the SRP, almost always, you can expect vertical increase. Why? Because you get this kind of expansion, right? Even in breaking patients. So this is something we have to deal with when we do SRP. So let's compare Hyrax versus SRP. Hyrax, you have to overcome the resistance. SRP, not so much. Surgeon help us. So you can expect much more meaningful skeletal changes with the SRP compared to the Hyrax. However, we're using the same appliance, the Hyrax for expansion. So the pattern of expansion is similar. V-shaped expansion there, V-shaped expansion here. So with either case, we can expect very little superior expansion. Most of the expansion will be in the inferior part of the maxilla. What about pterygopalatine suture? What would happen with the surgery? We try to disarticulate here. But what about up here? Zygoma gets in the way. So you have to put the instrument way up here. But the problem is, there are lots of vital structures up there. So we need to be very careful. This is one of the reasons why that SRP usually is done in a OR, not in the church side. Potential complication, right? So even with the SRP, we can expect some residual resistance. So when we do SRP, similar. We have a V-shaped expansion. Just a more skeletal component with the SRP compared to the Hyrax. But the pattern of expansion is very similar, like this. So this is a SRP patient. Okay? You get lots of anterior expansion, much less posterior expansion. This figure came from this first study, but there are many other studies showing the same thing. So it's a general consensus. SRP will give you mostly anterior expansion with a much less posterior expansion. So that's when implant, this is about 2000, early 2000, microimplant became available to us. So that's when the bone expander started to emerge. So my journey with the MARPI began about 2004. So I was doing a lot of Hyrax at the time. And I had to deal with all the side effects I just talked about. So my idea was, why don't we combine bone anchor with the Hyrax? So that we can have bone expander rather than tooth bone expander. So at the beginning, I called it MARPI. Kind of made sense. And I had really good results. I started to teach at the university. They started sending me to all the scientific meetings. And then I realized I was not the only one. Many doctors started Murphy. But if you look at it, similar concept. And what is a Murphy? Murphy is any expansion device with a bone screw in it. Right? That's Murphy. Bone anchored expander is Murphy. So all these are Murphy. But the problem was, each and every Murphy was giving us different result. But we call them Murphy. Not like a cancer, right? We call it all the cancer, patient's cancer. However, prostate cancer behave very differently than lung cancer, right? Speed of the spread and all these things are very different, right? Same thing with the Murphy here. This Murphy, where's the force vector? Wherever the screws are, right here, right? So force vector will be anterior, little bit inferior. What about this one? Way up high, okay, at the colorful hole. So more superior force vector. And horizontal AP-wise, it'll be somewhere there. What about this one? Skeletal anchor anteriorly. So we can expect lots of skeletal changes anteriorly. Posteriorly, toothful, right? So we can expect a lot of dental changes, which will be very different than this one. No tooth involvement here. Right? What about this one here? 4 screws. Freely cover and you expand. So one thing unique about this expander is that you can place screw anywhere you want. Okay? If you place screw inferiorly, you get inferior expansion. Superiorly, you get superior expansion. Anteriorly, posteriorly, same thing, right? What if you don't think about these things? Place screw wherever you find the bone. What if the right side is low, left side is high? Then you're going to have an expansion force that's lopsided. You're going to end up with a canting, right? What if on one side you find the bone anteriorly, and then the other side posteriorly? Then you have a lopsided force vector like this, right? So even with the one appliance, you can have many different results. Especially if you don't know what you're doing. You can have a massive complication. So point I'm trying to make, all these appliances give you different results. Yet we call them RB, the same name. So that's where the confusion began. Because when we start to publish our papers, one market study will say one result. Another market study like mine will say something else. So very confusing. So it became very confusing for the readers. So about 2013, I came up with the name MSC. So I can differentiate what this particular appliance will do compared to all the other markets. So what's the difference between Murphy and MSC? Murphy is any expansion device with a bone anchor in it. MSC is also Murphy, but one type of Murphy, unique Murphy. Okay? So one of the many Murphys. And then people ask me, what's so unique about MSC? So let me try to explain the difference between MSC and all the other Murphys. Because there are so many different Murphys. To make it very simple, I can categorize all the Murphys in this world into two types. Okay? First type, resistance-driven system. Second type is a bone-driven system. So MSC is a resistance-driven system. So what is the resistance-driven system? Resistance-driven system is an appliance that creates a force vector through the center of the resistance. Kind of like a tooth movement. If you put orthodynamic force through the center of resistance, you get bodily movement. If you push against the crown, you get tipping. So if you have expansion force through the center of resistance, you get bodily expansion. Okay? Not a tipping type of expansion like Hyrax and Sarpi. So that was the idea. So considering these three structures, we wanted to find where would be the center of a resistance for the skeletal structure. So here are all the red circles. And center of resistance for maxilla that we learned in school is very different than center of resistance skeletal. Why? Because in school we're talking about tooth, right? Dental center of resistance. Here we're talking about skeletal center of resistance.